and participants who have joined from various parts of India and abroad. Welcome to this live webinar. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speaker, Dr. Tejinder Singh from Gurugram, all discussants and participants to this virtual symposium on utility of immunohistochemistry in diagnostics hematology, part 1, acute leukemias and MDS. Before we commence the proceedings, I would like to welcome and introduce the host and convener for this webinar under the aegis of Mumbai Hematology Group, Dr. Amit Khurana. Dr. Amit Khurana is a senior hematologist and bone marrow transplant physician from Surat in western part of India. I request sir to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit. Let me share the screen. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from the rest part of the world. Today, our guest speaker for the day is no other than Professor Dr. Tejinder Singh from Gurugram, and he's going to lecture us on utility of immunohistochemistry in diagnostic hematology, part 1, acute leukemia and MDS. This webinar, as usual, is brought to by Mumbai Hematology Group, supported by Zydus dedicated to life, and very well managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and Team Zydus, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, no other than Dr. Tejinder Singh from Gurugram. All our discussants who are themselves very eminent hematologists as well as medical oncologists, and you participants for sparing a Saturday evening, morning or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 22nd of June 2025 from 11:30 a.m. Indian Standard Time and 8 a.m. Spanish time, we have Dr. Maria Victoria Matthews from Spain speaking to us on managing multiple myeloma in 2025, what is new. Let me introduce our discussions for the day, and they are displayed here in alphabetical order. I stopped for a while for you to have a look on all our discussions for the day. So these are our discussions for the day. Some more. These are very important personalities all over India and very eminent hematologists all over India. Well, now it's the time to introduce our guest speaker for the day. We have with us Dr. Tejinder Singh from Gurugram. Dr. Tejinder Singh is Senior Consultant, Onquest Lab, Gurugram, former Dean of Faculty of Medical Sciences, Delhi University, formerly Professor and Head, Department of Pathology at Maulana Azad Medical College, Delhi. He is also the past President of Indian Association of Pathologists and Microbiologists, that is IAPM, also the past President of Indian Society of Hematology and Blood Transfusion, ISHBT, Fellow of Indian College of Pathologists, Fellow of Indian Society of Hematology and Blood Transfusion, and has authored 7 books in hematology. Today is with us and is going to lecture us on utility of immunohistochemistry in diagnostic hematology on acute leukemias and MDS. This is part 1. Well, thank you so much. I stopped for a while. Over to you, Dr. Tejinder Singh, sir.
Slideshow I can't see on the screen.
Sir, if you can minimize this screen first.
Because
Here, right hand corner, you've got minimize button.
I can't see the
Right?
slideshow, and then audio, video, participant, chat, share.
Right above you have got minimize screen option. Right above, if you can just go for minimize
Right
screen.
above the?
Right hand side above you have got minimize screen option.
Okay, right hand side.
Minus sign. Very topmost. Still more up more. Left. Yes.
This is favorites.
No, the above one, minus sign. Above one, still above. No, now above, yeah. The minus sign. Right side. Yes. Minimize option, yes. Now you can work it in the PowerPoint mode. Lower down, right side. Lower down, right side. There is a PPT button. Yes. Perfect.
Okay, thank you, Dr. Khurana. And at the outset, I would like to thank Professor M.B. Agarwal for inviting me to be part of this teaching program, which has been going on for almost 3 years now. Today, I'll be talking about utility of immunohistochemistry in diagnostic hematology. I have divided the talk into 2 sessions. Today, I'll be taking acute leukemias and MDS. And in the next session, which is likely in middle of September, I'll be taking lymphoproliferative disorders and multiple myelomas. Now, we all know that for diagnosis of acute leukemias and MDS, we have to go with morphology, cytochemistry, and then immunophenotyping of acute leukemias. Immunophenotyping we can do in 2 methods. One is flow cytometry, and the second one is by immunohistochemistry. The method of choice for doing immunophenotyping, of course, is flow cytometry. There are no two views about it. However, in 10 to 15% of the cases, we are not able to get adequate bone marrow. And therefore, we have to tell the clinician whether a particular case is of AML or ALL and whatever subclassification we can give. And therefore, immunohistochemistry is of great importance in all such cases. Moreover, it is a universally accessible now. In almost all the medical colleges, we find that immunohistochemistry is available. And it can detect actually both nuclear antigens as well as cytoplasmic antigens like flow cytometry. But the basic advantage remains is that the architectural features and the cellular morphology is maintained in the peripherin sections. And being in a peripherin section, we can take the old material and carry out immunohistochemistry in these cases. I have divided the talk in these following subheadings. First is how to diagnose acute leukemias. Then second is, that is by peripheral smear, bone marrow aspirate, and assess the morphology. Then go on to the cytochemistry to distinguish AML from ALL. Cytogenetics and molecular is now integral part of a workup in a case of acute leukemia. And then blast immunophenotyping with lineage is most important. So once we reach the immunophenotyping, for that we can do by flow cytometry, and second is by immunohistochemistry. And so I'll go with the indications, especially in cases of dry tap, then IHC of BALL, IHC of TALL, then immunohistochemistry of AML, And finally, does immunohistochemistry help in detection of remission or relapse? And then I'll go over briefly immunohistochemistry in diagnosis of MDS. Now, one of the prerequisites for immunohistochemistry is we have to have a bone marrow refined biopsy. It should be properly decalcified. Decalcification is the most important thing in any bone marrow refined biopsy. The preferred method is 10 to 15% EDTA, disodium salt. Otherwise, in most of the labs, what they usually use for decalcification are the formic acid, acetic acid. If we use strong acids like picric acid or nitric acid, these are actually commercial decalcifying agents and they destroy the epitopes. That is, the antigens are destroyed and therefore we don't get good staining by the markers. The decalcification time therefore varies depending upon the decalcifying agent. It may vary from 15 minutes to 72 hours. EDTA, which I am recommending, is a relatively slow-acting decalcifying agent, and it takes minimum 1 day, and at times we have to wait for 3 days. And the epitopes of various receptors remain intact with EDTA. That is the basic advantage. Second decalcifying agent I would suggest is formic acid, and formic acid is used all over India in almost all medical colleges. However, decalcification also leaches iron, and therefore the iron assessment on a refined biopsy cannot be done. And then we carry out the sections, and the staining of the sections we always do with hematoxylin and eosine. GIMSA may be carried out if we want to identify plasma cells, mast cells, and then reticulin assessment is now an integral part. And if we find collagen, we can confirm by using Mason's trichrome stain. Now, I'm not going into the IHC protocol because it varies from medical college to medical college and from lab to lab, but the basic steps remain the same. One is antigen retrieval, which we do with pressure cooker, and then blocking with 4% hydrogen peroxide. And then we apply the primary antibody for 15 minutes. And finally, to give the color, the brown color, which we get positive color, is by dab. Now here again, the time varies, 10 to 15 seconds, and then wash in running water. And the counter stain we are using, as you can see, the blue dots, these are the nuclei. Now, first of all, I'm going to discuss the normal bone marrow, what all cells we come across and which markers we use. Now, this is the normal bone marrow with erythroid hyperplasia. But you can see the positive cells are actually the erythroid precursors. Now, these islands of erythroid precursors are present in the central part of the marrow. And these normoblasts stain with two markers which are usually used. One is CD235A, that is a glycophorin A, and CD71 is the membranous one. And the one you are seeing now is CD235A. Both are equally good. However, we find that the CD71 is better whenever we have a case of erythroleukemia. Second, we come across are the myeloid precursors which are present in the bone marrow. But you can see where the arrow is, this area is actually the bony trabeculae. And what you find here, the cells which are paratrabecular, just hugging the bony trabecula, these are the myeloblasts and the promyelocytes. And then as we go towards the central part of the marrow, you find myelocytes, metamyelocytes, and polybuffs. So this is the location of the normal myeloid precursors. And the blast cells can be demonstrated using CD34. Promyelocytes and even the blast can be demonstrated using CD117. Then the matured cells, which are in the central part of the marrow, they take up CD13, CD33, and CD15 stains. So which are the myeloid series cells which we usually are using in hematology cases? One is the blast cells. Which stains we do for the blast? Which are the markers we are using are the CD34 HLA-DR, CD117 and of course, MPO. Then for promyelocytes, we find that the HLA-DR is negative, CD34 is negative. However, CD117 is positive along with myeloperoxidase. Then we have the myelocytes where we find that these are positive with the CD15, and of course, myeloperoxidase is positive along with CD33 and CD13. Mature myeloid precursors are again positive with CD33, CD13, MPO, and CD15. Sometimes we find that the neutrophils also take up CD10 positivity. What about the lymphoid cells? Now, the normal lymphoid cells are present in the bone marrow. Now, we find that immunohistochemistry is slightly different in bone marrow as compared to the routine histopathology which we carry out to diagnose the various malignancies. Here, the cells which are benign or malignant are always present in the bone marrow. Say like lymphoid cells, they are in the marrow. They are of both types, CD3 as well as CD20 positive cell. So which ones are more? T lymphocytes are 3 to 6 times the number of B lymphocytes. As you can see in this case, the CD3 cells are about 4 or 5 times more than the CD20 positive cells. Now, the T lymphocytes on immunohistochemistry are positive with CD2, 3, 5, CD7, CD4, and CD8. But out of all these, the most important one is CD3, both cytoplasmic as well as membranous. This is a lineage-specific marker for T series, for the T cells. CD2 is the earliest T cell marker. Then we have the B lymphocytes, which are CD20, CD19, CD22 positive, along with CD79A. PAX5 is a very good marker for B lymphocytes because it is positive right from the lymphoblasts, which are B lymphoblasts, and it goes through the whole maturation right up to mature B cells. PAX5 is positive in these cells. So it is going to be positive in both blast cells. It is going to be positive in lymphocytes also. Now, CD79A is another marker which we use because CD79A, like PAX5, is also expressed throughout the differentiation of the B cells. Now, out of these, we are commonly using CD20 very frequently, especially in cases of lymphomas, because the lymphomas are arising from mature B cells. And for mature B cells on immunohistochemistry, CD20 gives very good results. Now, this is a normal lymphoid aggregate, which we find in people who are over 50 years of age. And sometimes this may be confused with a lymphoma deposit or for a case of CLL, but it may not be so. Excuse me, this could be a normal lymphoid nodule which is present in people over 50 years of age. And how do we confirm it? Now, in this particular case, we have done CD3. Majority of the cells are CD3 positive, especially in the central part of this lymphoid nodule. And the CD20 cells are at the periphery of this nodule, and their number is low. Now, this is the typical picture in a case of benign lymphoid nodule, which we come across in normal bone marrows in old people. On the other hand, which we will talk about next time, suppose this is a case of a lymphoma, then we will find that more than 80 to 90% of the cells will be CD20 positive if it is a B lymphoproliferative disorder. And if it is a T lymphoproliferative disorder, then almost all the cells will be CD3. And when we find combination of both the CD3, CD20 is present, we know that these are the benign lymphoid nodules. And of course, there are other differences, morphological differences between the benign and the malignant lymphoid nodules. Now, the NK cells and LGLs are positive with CD8 and of course CD16, CD56, and the LGLs we find are also positive with the CD8. Now, in the normal bone marrow, the CD4 cells are more than CD8, and the ratio is usually more than 1. Macrophages. Now, sometimes we are not able to appreciate macrophages, so we carry out CD68, and once in a while we use it even for cases of HLH to demonstrate the hemophagocytosis which is going on. And CD68 is a marker we use for macrophages as well as for monocytes. Then we go on to the largest cell in the bone marrow. You can see the multiple megakaryocytes. Here you can find the blue one is the nucleus and the brown is the cytoplasm of the megakaryocytes. So all stages of megakaryocytes, right from megakaryoblast to promegakaryocyte to megakaryocytes, they are all positive with CD41, CD61, and CD42B. And therefore, we can utilize this property, number one, to rule out or to diagnose cases of amegakaryocytic thrombocytopenia. Then we can use it in cases of MDS as well. Then mast cells are positive with CD117 and the mast cell tryptase. These are the two markers which we commonly use. I'm sorry, you can't see the pictures. Anyway, we'll see. Yes, right now. Here we can see the mast cells. These are spindle-shaped cells which are seen amongst the stromal cells of the bone marrow. Their number increases in cases of mastocytosis, which may be a secondary mastocytosis, or it may be a tumor or malignancy of the mast cells. Now, what we find here are these large cells having eccentric nuclei, large amount of cytoplasm, and their location is pericapillary. You can see this is one pericapillary collection of plasma cells. Here also the plasma cells are pericapillary location. Now the pericapillary location is highly suggestive of a benign plasmacytosis rather than multiple myeloma plasmacytosis, where we don't find pericapillary accumulation, but we find aggregates of plasma cells or replacement of the normal hemopoietic elements by plasma cells. Angiogenesis we can study in a bone marrow. CD34 and CD31, these are the two markers we use. All the endothelial cells and the angiogenesis, the new vessel formation can be seen. It was at one point of time, say about 15 years back, angiogenesis was very, very important because we knew that in cases of acute leukemia, chronic myeloproliferative disorders, and myelofibrosis, the angiogenesis would increase. So in acute leukemia, it was also decided to try anti-angiogenic drugs which may reduce the angiogenesis and maybe it may benefit the patient in some way. However, it is still going on. Some drugs are on trial on this. Now, with this introduction to immunohistochemistry, we go on to the role of immunohistochemistry in diagnosis of acute leukemias. You can see a picture of acute leukemia, the blast cells. Now, these blast cells are present here in the peripheral blood, but more often for diagnosis, we have to carry out a bone marrow aspirate so that the whatever cells are present in the bone marrow, those we can visualize, and depending upon that, we may make a diagnosis depending on morphology, cytochemistry, and immunophenotyping of the leukemic cells. Here what happens is the blast cells are present and there is a failure of differentiation. That is, they don't mature onto neutrophils or they don't mature onto lymphocytes, and there is an uncontrolled cell proliferation. So what I'm going to talk about is how to diagnose acute leukemias. Number one, lab investigation is morphology. Morphology is the most important to see how many blast cells are present in the peripheral blood film. Number one, what is the morphology of the blast cells? Are they really blast cells? Are those lymphoma cells? Are they transformed lymphocytes? So we need to distinguish and come to a conclusion that there are blast cells in the peripheral blood film. Then we carry out bone marrow aspirate. And in the bone marrow aspirate, again, we are studying the morphology. Sometimes we find that there are two morphologies of the blast cells. One is sort of lymphoid, the other one is myeloid. So we study the morphology, and morphology in the bone marrow aspirate was the basis of FAB classification way back in 1976, which still holds true. And we are always dependent upon M0, M1 to subclassify acute myeloid leukemia. Then we carry out cytochemistry. Now the cytochemistry, for cytochemistry, we need either peripheral smear if the blast cells are present in the peripheral smear, or bone marrow aspirate. Sometimes the bone marrow aspirate is diluted, but the biopsy comes out good. So usually we make imprint smears of the bone marrow trephine biopsy, and those smears are as good as bone marrow aspirate smears, and we carry out cytochemistry and study morphology of the leukemic cells. Following cytochemistry, we go on nowadays on to the cytogenetics and the molecular studies to come to a conclusion what type of leukemia we have. But what is more important before we go on to cytogenetics and molecular is immunophenotyping. What is the lineage of the blast cells? Only then we go for cytogenetics and molecular, because here, based on the lineage, whether it is a B cell, whether it is a precursor T cell, whether it is a AML, we decide, and then subclassify and come to a conclusion with cytogenetics and molecular, which not only gives us the accurate diagnosis, but also gives us an idea about the prognosis and the which treatment to be given depending upon whether it is B-ALL, T-ALL, or AML. So the blast immunophenotyping with lineage, how we can do that? We can do it by two methods. One is with flow cytometry, and second is by immunohistochemistry. So immunohistochemistry we do for confirmation of the lineage and diagnosis. And what are the indications? The indications for immunohistochemistry are, number one, dry tap. If we find a dry tap, we don't get good bone marrow aspirate, we are not able to do flow cytometry. Since we are not able to do flow cytometry and we need immunophenotyping with lineage, then we go for immunohistochemistry on a bone marrow trephine biopsy. So what I'm going to talk about is immunohistochemistry of B-ALL, of T-ALL, immunohistochemistry of AML, and then how does immunohistochemistry help us in detection of remission and relapse? And finally, IHC in diagnosis of MDS. So we have talked about PS, bone marrow aspirate, cytochemistry, and then flow cytometry and IHC for confirmation. And depending upon the type, then we go for cytogenetics and molecular genetics. And finally, we give the therapy and then we assess the MRD. And for MRD, again, immunophenotyping is must. Now, this is just to give you a glimpse of acute leukemia case. This one is ALL, the other one is here, the nuclear chromatin is more open, is AML. Now, which are the stains we are using for cytochemistry? Myeloperoxidase. This is the most important stain which we use in hematology after GIMSA. Here you find a case of AML, which is showing positivity, blue color. And here you find an OR rod, which has come out positive with myeloperoxidase. Myeloperoxidase is a marker of myeloid series. Almost all AMLs, except with exceptions, of course, are positive with myeloperoxidase. Then we have Sudan black B. Now, Sudan black B it goes hand in hand with myeloperoxidase. Nowadays, we are using Sudan black B more for diagnosis of L3 cases or the Burkitt leukemia or Burkitt lymphoma, where we find that there are multiple vacuoles in the cytoplasm and we find that these contain fat. and it is positive in Sudan black B. PAS positive, here you are finding the pink blobs of material. We call it as block positivity, since blocks of this pink material is positive. It is highly suggestive of acute lymphoid leukemia. On the other hand, we find that the TALL cases, TALL cases, they demonstrate acid phosphatase positivity, and this brownish orange color, which you are seeing, which is polar, is positivity for acid phosphatase. Here you find double esterase. Now, double esterase is very, very useful in cases of myelomonocytic leukemia. Here you find two type or two shades of cells. One cells are orange colored positive. The other ones are blue, which are positive. The blue ones is the myeloperoxidase positivity. Here, the monocytoid cells are demonstrating this orange color positivity. So this stain, double esterase positivity, that is non-specific esterase for non-specific esterase is for monocytoid, and the chloroacetate esterase, the blue one, is for myeloid. So we can confirm the presence of myeloblasts, confirm the presence of monocytoid cells in a case of acute myelomonocytic leukemia. Now, by and large, 80% of all leukemias can be diagnosed by morphology and cytochemistry alone. Then what are the indications for flow cytometry? Because that is what we always go for. Cytochemistry, we make an opinion, and then we go for lineage by flow cytometry. Number one, to know whether it is a precursor T cell, precursor B cell, or it is AML. So we get a lineage and differentiation, how much differentiation of the cells has taken place. Is it pro-BALL? Is it pre-BALL? Or it is BALL, which it is Burkitt type or L3 type. Then to know the response to treatment as well as prognosis. Now, depending upon the pro-B or pre-B or pro-T or pre-T or AML, whether it is myelomono, is it only monocytic, we get an idea and which treatment to give and how to go about the prognosis. And then MPAR, which is mixed phenotypic acute leukemia. Now, cytochemistry is not the method of choice to diagnose cases of MPAR because of the various myeloid and lymphoid antigens which are stronger, and they bring about the minimal antigen presence also. And therefore, flow cytometry is the diagnostic modality of choice for diagnosis of MPAR cases. Besides this, AML M0, or what we now call as AML minimal differentiation, MD, and for diagnosis of acute undifferentiated leukemia, where we do the cytochemistry, and even after flow cytometry, we find that the antigens are not demonstrable, and those are labeled as acute undifferentiated leukemia. We all prefer immunophenotyping by flow cytometry. Advantage being that we analyze a high number of cells. That is number one. Second is that we can see the expression of several antigens on an individual cell. Now, that is where the disadvantage of immunohistochemistry is, that at a time we can demonstrate only one antigen. On one slide, we are able to demonstrate one antigen. For the second antigen, we take another section. For the third one, we take the third section. Then several antigens, both cytoplasmic and surface, are analyzed, and the lineage assignment is given in mixed phenotypic acute leukemia or MPAR. And then we come across the aberrant phenotype. Now, this aberrant phenotype or a aberrant expression of various markers helps us in detection of MRD. But in 15 to 20% of the cases, flow cytometry is not possible for various reasons, because it may be a dry tap, it may be a diluted bone marrow aspirate, it may be inadequate marrow, and we are not able to carry out flow cytometry. So what to do in these cases? In such cases, we carry out immunohistochemistry on the bone marrow biopsy. So why do we get a dry tap? Number one, as and when there is a fibrosis of marrow. And when does fibrosis of marrow occur? It occurs in acute leukemias, myeloproliferative neoplasms, metastatic deposits, multiple myeloma, almost all cases of Hodgkin disease, hairy cell leukemia, non-Hodgkin's lymphoma, MDS fibrotic type. And then if there is a hypoplastic marrow, like in aplastic anemia, or MDS hypoplastic or hypoplastic AML, we come across again a dry tap. Similarly, if it is a compactly cellular marrow, very, very hyperplastic marrow, and it is just full of cells, aspirate is not possible. So these cases are of acute leukemias, lymphomas, and multiple myelomas, and some cases of MDS, which are of hypercellular type. Now, this is what I meant. Densely packed marrow, you can see, though it is full of cells, but you apply suction and we don't get a good bone marrow aspirate. So what we have to do is do a triphyline biopsy and carry out immunohistochemistry. Now, this is fibrosis. You can see the streaming of the cells because of the increased reticulin, as we are not able to get a good aspirate, and therefore we go for immunohistochemistry. Here you find bone marrow necrosis. These are just ghost cells which are present in the bone marrow. So the leukemic cells in the marrow have undergone necrosis, and we don't get good bone marrow aspirate, and whatever we are getting are the necrosed cells. We cannot diagnose. So we go on to bone marrow triphyline biopsy and do immunohistochemistry. A 49-year-old lady complained of weight loss, fever, night sweats, mild splenomegaly, and there is pancytopenia with TLC 1600, low hemoglobin, and low platelet count. Bone marrow aspirate was tried. It was a dry tap. And there were inadequate cells on the bone marrow imprint. Suspected acute leukemia, and bone marrow biopsy was advised. And what did biopsy show? The biopsy showed marrow with lymphoma oblique leukemia cells. These are immature cells with vesicular nuclei, open chromatin, and with presence of nucleoli. Looks like lymphoma, could be a acute leukemia, but the bone marrow aspirate was inadequate. Now, why was this compactly packed cells, and yet we find, and there is also increased reticulin. This is the reticulin stain. You can see these fibrils. These are the reticulin fibrils. So any case in which there is a fibrosis of the marrow of acute leukemia, we are not able to get a good bone marrow aspirate. And therefore, we have to do a bone marrow triphyline biopsy as in these cases, and then arrive at a conclusion. So what we did for this lady is immunohistochemistry was carried out. CD34 was positive, MPO positive, CD117 was positive, so was CD68. So highly suggestive of acute myelomonocytic leukemia. Now, immunohistochemistry is a time-tested and reliable method for immunophenotyping. What are the advantages? There are certain disadvantages versus flow cytometry, but the advantages are like architectural relationship is maintained. The way the cells are arranged in the bone marrow, it gives an idea about the architecture of the cells which are present. And then low number of neoplastic cells, as happens in Hodgkin's lymphoma, where the CD30 cells are rather few, or T cell rich B cell lymphoma. Then CD34 facilitates the detection of blasts and their distribution pattern. And then we don't require a fresh tissue. Once you have done a biopsy, you have seen the morphology, and on that you have done the reticulin stain to demonstrate the fibrosis. Now we don't need fresh tissue. Same block, multiple sections are cut, and then we carry out the immunohistochemistry on that. Now, which are the markers we use for acute leukemia? What we need are the immature markers, which can describe positivity, may indicate that the cells are precursors, immature cells. Now, these are CD34, TDT, CD117, and HLA-DR. These are the four markers which are used to confirm that the cells are immature. What about CD45? Now, CD45 is a very important marker. because it recognizes hemopoietic origin. So we carry out CD45 as a first marker to confirm that it is the cells are of hemopoietic origin. This is to distinguish from metastatic deposits. Sometimes round cell tumors or the small cell tumor of the lungs, such morphology, they get confused whether we are dealing with a case of acute leukemia, is it metastatic deposit, so we go for CD45. One more important thing is that CD45 is very strong in NHL and it is weak in acute leukemia. So once you do CD45, then you have already made up your mind whether it is likely to be a case of NHL or it is likely to be a case of acute leukemia. Okay. And then we go for the markers of immaturity, which I told you. Now, what we find is that in the blast cells, especially in undifferentiated blasts, TDT is the strongest. And TDT is very sensitive by immunohistochemistry. See this. TDT is positive in 99% of the TALL. It is positive in 95% of the BALL. And only 20% cases of AML are positive for TDT. So if we find that in a particular case of acute leukemia by immunohistochemistry, TDT is positive, we are dealing with a case of acute leukemia. And of course, we have already seen that CD45 is weak in acute leukemias. Now, CD117, it strongly favors a myeloid lineage because this is also positive in promyelocytes, of course, in mast cells and early proerythroblasts sometimes. So CD117 is a marker for myeloid lineage, which we do. Now, how to proceed for immunohistochemistry in acute leukemia? We don't put up all the markers at one go. What we usually do is, first thing is, as I said, is a CD45. And we see if it comes out to be positive, whether these are hematopoietic. If it is weak or is it strongly positive, we distinguish between lymphoma and acute leukemia. And if you find TDT positive, fantastic. It indicates blasts are present. And then 117 is positive, that means myeloblasts are there. And then MPO is positive in the myeloblast, so it confirms a myeloid lineage. And similarly, PAX5 confirms the B cell lineage and CD3 confirms the T cell lineage. So these initial 6-7 markers give us an idea about lymphoma versus leukemia and what kind of blast cells are, whether B, T, or myeloid. And then we go further, especially in myeloid immunohistochemistry, to see whether it is monocytic or is it myelomonocytic. So we go for CD68 for the monocytic origin. For the erythroid, we go for CD71 or CD235. And then CD61, we go for megakaryoblastic. Now, this is a usual panel. And then, of course, there are other markers which we keep on adding depending upon the case as we go along. So ALL, we subclassify into two types, whether it is B-ALL or it is a T-ALL. And for B-ALL, we have the various markers like CD10, CD19, and of course, the immaturity markers, TDT, CD34, and PAX5 is a lineage marker for B-ALL. Advantage of the PAX5 is that it is a nuclear marker. T-ALL, CD3 is the marker. It is a lineage marker for TALL. TDT is also positive in almost all majority of the cells of TALL. So TDT and CD7 expression. Others like CD1A, CD99, and CD34 are positive in 50 to 80% of the cases. Early T precursor ALL, it displays a weak or absent CD3 and dim to negative CD5. But it is difficult to diagnose early T cell precursor unless we have a battery of the markers and we carry on these markers to confirm that it is early precursor TALL. We should keep in mind that the flow cytometry and molecular studies remain the gold standard for diagnosis of ALL. And immunohistochemistry serves as a reliable alternative. Cases where there is a dry tap or inadequate marrow, or it is not possible to repeat the bone marrow aspirate, we go for immunohistochemistry. Now, what is a B cell panel? Now, the B cell panel consists of CD19, CD20, 79A, 22, and PAX5. PAX5 is a B cell lineage marker. Now, CD20 is a very good marker. It is a pan B cell marker for mature B cells. But here in acute leukemia, we have the immature cells, precursor cells. Therefore, CD20 is usually negative, except for the few cases in which CD20 may also turn out to be positive. Along with, of course, one may come across that in then CD79A or PAX5 are present in these cases, along with CD10. Now, CD10, of course, is a marker for germinal center B cells, and we use it along with BCL2 and BCL6 for diagnosis and subclassification of non-Hodgkin's lymphomas. Now, this is to see the maturation of B cells. Now, as we can see here, the TDT and CD34. Now, these are the markers for immaturity, so you don't find them in the mature B cells. So it falls short of, it is only for immature B cells you find TDT and CD34 are positive. On the other hand, the CD19, which we use extensively in flow cytometry for B cells, whether lymphoma or leukemia, CD19 is present in the precursor B cells, and then throughout the ontogeny of these B cells, you find even in mature B cells, CD19 is positive, so we can diagnose non-Hodgkin's lymphoma as well with CD19. And then we have the similarly to CD19 is 79A and also PAX5. Now CD10 is positive in precursor and also in the mature B cells. And then, of course, we have the BCL6, which is seen for germinal center lesions, especially the germinal follicular lymphomas. Or in cases of bucket lymphoma, we may come across the positivity. Now, this is a typical staining in a case of BALL. See, the aim, as and when we are diagnosing a case, is we have to demonstrate that this is a case of BALL, that BALL markers are positive. At the same time, what is coming behind this is that the myeloid markers are negative and the T markers are also negative. So here we find CD34 TDT. 2 are positive, which indicate immaturity of the cells. CD20 is negative. Since CD20 is negative, this indicates that we are not dealing with the mature B cells. These are immature B cells. Then we have the PAX5 is positive. PAX5 is a nuclear stain and it is positive. It is positive in the lymphoblasts as well as in B lymphocytes, so that is positive. Then we have to demonstrate that CD3 is negative. Yes, it is negative. 79A is another B cell marker which is positive in the lymphoblast, that is positive here also. And myeloid marker, the CD117 is negative. And the CD10, a B cell marker, is positive. So we have demonstrated the B cell markers are positive, T is negative, and the myeloid is also negative. After B, we go on to the T cell antigen. Now, T cell antigens are CD2, early T cell marker, and CD7 is also an early T cell marker, while CD3, the lineage marker, is pan T cell marker. It is present throughout. That is right from the T lymphoblast onto the T lymphocytes. These are positive. But we have to keep in mind that T cell ALLs, about 20 to 30% of the cases also demonstrate CD1 positive, and few cases will demonstrate even CD99 positive also. So which are the two markers which by and large clinch the diagnosis are CD3, which is a lineage marker, and TDT positivity. TDT positivity indicates the immature T cells. CD3 is also positive in immature T cells. So these two combination. And of course, we have the CD2, CD5, and CD7. These are variably present. Now, the T cell maturation, it can be divided into, which is occurring in the thymus, is cortex and medulla of the thymus. So cortical stage and the medullary stage. Now, what we find is that TALLs, acute leukemias, they express cortical thymocyte phenotype. And the T non-Hodgkin's lymphomas, they express medullary thymocyte phenotype. So therefore, you find that it will correspond to the medullary thymocyte phenotype, while TALLs correspond to the cortical one. And that is why we find that CD1A and CD99 are positive in about 15 to 30% cases of TALL. So here it is CD99 expression in TALL and CD1A, CD99. Okay. Then we have the medullary T lymphocytes, which are positive in cases of T non-Hodgkin's lymphomas. Now, this is to show you the expression of various markers. TDT, CD34. CD34 is not as commonly positive as in BALL. However, TDT, CD34, these are the two markers of immaturity. Then we have the 1A is also marker of immaturity and also cortical type. Then CD7 and CD2, these are the early T cell markers, and both of them persist right up to the maturation up to T lymphocytes. Then we find CD3, which is the lineage marker. Cytoplasmic CD3 is positive in cases of immature T cells, and that is why we are always doing the cytoplasmic CD3 while doing flow cytometry. And then as these cells mature, the lymphocytes become either CD4 or these become CD8. So the TLL can be double positive. Double positive means co-expression of CD4 and CD8, or some cases are negative. CD4 and CD8 negative, that is for both CD4 and CD8. On the other hand, the mature T cells are either CD4 positive or they are CD8 positive. Now, this is a typical thing, TALL. There is some element of fibrosis in this. Dry tap, 34 is negative, but TDT is positive, so is CD3. CD99 is also positive. Now, the B cell marker, PAX5 is negative, CD10 is negative, so is MPO, that is negative. So immaturity markers and the lineage markers positive, and accordingly we label the case as BALL or TLL. Then we go on to the myeloid panel. Now the three markers are CD13, 33, MPO, and CD117 is equally important. So these 4 or 5 markers of great use when we are doing CD immunohistochemistry. Of course, myeloperoxidase is the most important thing, because if it is positive on cytochemistry, it is AML. If it is positive on flow cytometry, it is AML. If it is positive on immunohistochemistry, it is again AML. Now, CD117 is expressed on most hematopoietic progenitor cells, except, of course, for megakaryocytes and also early erythroblasts. Now, CD68 is a marker for monocytic series and also lysozyme. So in cases of myelomonocytic and monocytic, we use CD68 extensively. Now, how we are using nowadays immunohistochemistry in which cases is that AML has been classified by WHO into 5 groups, with recurrent genetic abnormalities, with multilineage dysplasia, with MDS and AML, and then AML NOS and AML of or acute leukemia of ambiguous lineage. Now, these first 3 entities, these require genetic and molecular studies. What is left is AML not otherwise recognized. Now, this is where in these cases, immunohistochemistry is very, very useful in this fourth group. Now, which is this fourth group? Which are the acute leukemias in this one are minimal differentiation corresponding to M0 of FAB. Then we have myeloid leukemia without maturation, then with maturation like M2, acute basophilic leukemia, myelomonocytic, M4, monocytic, M5, acute erythroid leukemia, what we used to call it as M6, and of course the M7, acute megakaryoblast leukemia. Now, these are the acute leukemias which we diagnose on immunohistochemistry. And then we carry out the subtyping. Say, for example, AML with minimal differentiation, that is M0, there is lack of MPO expression. So the MPO is negative. So what is positive then? If MPO is negative, TDT positivity. More immature the cell is, more is the TDT positivity. So M0 MPO negativity is seen in 85% of the cases. Then how do we diagnose these cases? Now it is seen that again we depend upon CD13, CD33, CD117, and usually about two markers or about two markers come out positive, at least two markers, then we label it as a case of AML. Now, CD117 is positive in 90% of the cases of AML. Now, this is very, very important. That is, it is positive in M0, M1, M2, M3, of course. Then M4 also, it is positive in some cases, few cases of M5 also, and once in a while in a case of M6 as well. Now, for monocytic, as I told you, that CD68 positivity is diagnostic. Now we are trying, and CD64 is also coming out to be positive. Earlier, we had only CD68, but now CD64 is also being used for immunohistochemistry for monocytic cases. When do we say that it is MPO positive? We should know the limit. More than 3% positive on cytochemistry, we say MPO positive. More than 3% positive on immunohistochemistry, again, we take it as MPO positive. And more than 10% positivity on flow cytometry, we take it as positive. So the blasts are usually in AML are positive for CD117 and HLA-DR. And CD68, of course, is variable in M4, M5A, and M5B. Now, AML as a group can have TDT expression in few cases, in about 20 to 25% of the cases. But of course, more cases are positive with M0 or minimal differentiation. 90% of the cases are positive. But at the same time, we have to keep in mind that the aberrant expression of 2, 5, CD2, CD5, or CD7 can occur in AML. Now, this is AML minimal differentiation. You don't find polymorphs, myelometa. 117 is positive. CD34 is positive. And MPO is negative. But TDT is positive. So MPO negative here, but here we find that 117 is positive. So in such cases of suspected M0, we always apply CD13, CD33, and CD117, of course, along with the MPO, which usually turns out to be negative. Then in M1, here now it changes. There, MPO was negative in M0, but in M1, without maturation, MPO comes out to be positive on immunohistochemistry. Of course, we are doing CD33 and CD30. And of course, the CD61, 71, all these markers are negative. HLA-DR and CD117 are positive. So here you find 34 positive, 117 positive, and MPO positive in M1. M2, of course, MPO is positive, 117 is positive, and we find 13, 33, and HLA-DR are positive. You can see the MPO positivity and CD34 positivity over here. For myelomono, myeloid lineage can be established on the expression of 117 and MPO. But in CD68, CD64, and CD163, and lysozyme, these are the four markers we use for monocytic differentiation. And CD68 is a reliable marker, but now CD64 is also a reliable marker, which we have used recently. And then AML myelomonocytic. Here we find that there is a differentiation towards the myeloblast. There is a differentiation towards the monoblast also. And therefore, we find that the blasts are positive for MPO and CD117, and the monoblasts are positive with CD68 and lysozyme. It is something like dual staining, which double esterase, which we are doing for cytochemistry for myeloid as well as monocytic. Same is with markers. Now, in these cases, we find that the CD4 also be positive in cases with monocytic lineage. Now, this is M4. So you find immaturity markers 34 positive, myeloid positive 117, MPO positive, and monocytic CD68 is positive. Now, CD68, we have two types. One is KP1 and PGM1. Now, PGM1 is, both of them are of course sensitive, but KP1 is more sensitive. And PGM1 is more specific. And but this antibody is less sensitive. We are using CD68, but with satisfactory results. And these cases of monocytic at times pose a problem, because we find that CD34 is negative in monoblast. Of course, HLA-DR is positive along with CD68 and lysozyme or CD64. Now, if we do CD68, you can see here we find M5 monoblastic. You find few granules are positive. On the other hand, in M5B, where we find the majority of the cells are monocytes and promonocytes, CD68 is very, very strongly positive in monocytic type versus monoblastic type. In AML erythroid lineage, of course, the morphology is very, very important. You find the round nuclei, prominent nuclei, open chromatin, basophilia of the cytoplasm, PS positivity in the cytoplasm is seen. Now, here, the two markers which we use are glycophorin A and CD71. Another one, E-cadherin, is important because E-cadherin is positive in early erythroid cells, proerythroblasts, and also P53 is also positive, though P53 indicates a biallelic TP53 mutation, and that is the one responsible for poor prognosis of cases of acute erythroid leukemia. CD117 may or may not be positive in these cases. Similarly, HLA-DR and CD34 are rarely positive in these cases. Erythroid lineage, here you find CD71 is positive, E-cadherin is positive, and of course one can do CD235 as well. Now, the cases of acute leukemia which have got marrow fibrosis, because such cases yield a dry tap. Since there is a dry tap, and therefore, because of the marrow fibrosis, this is what you find reticulin stain. And because of the increased reticulin, there is a dry tap. So fibrosis of the marrow occurs in megakaryocytic AML, M7. Secondary to MDS, again, fibrosis occurs. Therapy related, again, you find fibrosis is there. Secondary to MPN, like patient had CML or PMF and now has gone on to a blastic phase. Similarly, in acute pan-myelosis with myelofibrosis, you find there is a marrow fibrosis. And in any type of AML, one can come across. So the marrow fibrosis can occur in any type of acute leukemia. So we should be aware of this fact. And that is why you find here in the peripheral blood, there is a pancytopenia. There is a grade 1 to 3 fibrosis. You can see in between the blast cells, the counts are very low, and you find there is fibrosis of the marrow. So dry tap on the bone marrow aspirate, and what we apply are the myeloid markers CD117, CD34, HLA-DR. Now, don't think that marrow does not occur in ALL. In ALL also marrow fibrosis occurs, but the number of cases and the degree of fibrosis is less. So here we do CD117, HLA-DR, CD34. And of course, in suspected cases, we always apply CD61 for M7 or megakaryoblast acute leukemias. Now, this is AML M7. Now, this is an imprint smear. Aspirate was again a dry tap because of the marrow fibrosis. In some of the blast cells, you will find there are blebs or the cytoplasmic projections on the blast cell surface. Sometimes large clumps of platelets may be seen or bizarre platelets may be seen. There are dysplastic megakaryocytes, fragments of megakaryocytes, and this is a biopsy showing you extensive fibrosis, megakaryocytes, and then these are the megakaryoblast. The megakaryoblast should be more than 20%, and more than 50% should be of megakaryocytic lineage, and then you find this fibrosis. So here you find the reticulin, and these are the various stages of the megakaryocytes along with megakaryoblast, and there are osteolytic lesions, and see this CD61 extensively positive in all the cells of the megakaryocytic series, including the blast cells. One can use CD41 and CD42 also. Now, this is M3 or acute promyelocytic leukemia. You can see the rods, the phago cells, extensive positivity with myeloperoxidase cytochemical stain, and here you find a Phe body in one of the this is hypergranular type. This is M3V showing you the pars, buttock-shaped cells you find, pinkish cytoplasm. And here you find the appearance of the cells is plasmacytoid. The nucleus is pushed to one side and there are granules in it. These are all promyelocytes, and which you can confirm with various markers. But here we find that the CD34 is negative, HLA-DR is negative. So what is positive is CD117 and the MPO. Few myeloblasts which may be present amongst the promyelocytes turn out to be positive. This is hypoplastic AML, looks like aplastic anemia, but here in between the fat cells, what you are looking at are the blast cells. So you should be very carefully examine all such cases where it looks like aplastic anemia coming to you with pancytopenia. If the vesicular nuclei with nucleolus are seen, it could be a case of AML. Confirm with CD34, MPO positivity, and CD117. This is a case of dental OPD, swelling upper gum. Biopsy was taken after treatment, no relief. And what we find are the sheets of these blast cells, which are MPO, CD117, CD34 positive, and the treatment could be instituted. What is the role of IHC in detection of remission and relapse? Hypercellular marrow, acute leukemia, give chemotherapy, there is a depletion of the leukemic cells. As a result, what happens? Reduced cellularity, hemodiluted aspirate. We do a bone marrow biopsy in such cases to look for remission or regeneration of the hemopoietic elements, or the blast cells are persisting. So relapse, remission, regeneration. What we find here in all these 1, 2, 3, 4, this is the gelatinous marrow transformation. The leukemic cells have disappeared, and these are secreted by the stromal cells. So the acid mucopolysaccharides are there, what we call a gelatinous marrow transformation. No blast cells. CD34 is negative, CD34 is negative. You find some lymphocytes are present, few plasma cells. And what we find here, these are colonies of regenerating erythroid precursors, and there are these megakaryoblast and megakaryocytes. Regenerating marrow. Some cases you find that the patient has not responded as well, resulting in persistence of the blast cells. So you find blast cells are present in the clusters, and then you carry out the CD34, 117, MPO, and you find it to be positive, confirming that this is what we are dealing with. I'll just go over MDS, won't take more than 5 minutes. We all know about MDS, clonal disorder number 1. Patients present with cytopenias, what we find is a hypercellular bone marrow. Yet the patient has pancytopenia. You can see the smear below, and it is showing pancytopenia. Another feature is dysplasia, accelerated apoptosis. What is important is increased risk of development of AML. How do we make the diagnosis? Diagnosis is based on morphological evidence of dysplasia. And also, now we have the additional studies of karyotype, flow cytometry, and molecular genetics. So what we do is assessment of the blasts, look for dyserythropoiesis, dysmyelopoiesis, dysmegakaryopoiesis, and then hypoplastic MDS or MDS with myelofibrosis. So the 4 pillars of diagnosis are cytopenias, dysplasia, clonal hematopoiesis, and increased blast cells in the peripheral blood and or in the bone marrow. Majority of the patients present with anemias or thrombocytopenias or a combination of the two. There are criteria for dysplasia more than 10% in more than one bone marrow cell line, presence of 5 to 19% blast cells in the peripheral blood or in the bone marrow. And there is a specific MDS-linked chromosomal abnormality. And there is a clonal proliferation, and of course, there are cytopenias. So how do we study the blast percentage is by CD34 and 117, then dysmegakaryopoiesis by CD61, dyserythropoiesis by CD71, and we go for P53 IHC because if positive, the risk of transformation is high. Now this is blast percentage. First thing is assessment of blast in the blood film, in the aspirate, or in the bone marrow biopsy by immunohistochemistry. We usually don't use flow cytometry for assessment of CD34 positive cells because of the fear of dilution in the bone marrow aspirate, and dysplastic megakaryocytes and proerythroblasts must not be counted as blast cells, except in pure erythroid leukemia. Now, this is a bone marrow defined biopsy. What you find are the blast cells which are present with vesicular nuclei, prominent nucleoli, and these are scattered over this, but less than 20%. So these are CD34 positive blasts. So this gives an accurate count of the blast cells. Now, this is what I showed you earlier also, that the normal location of the blast, myeloblast, is paratrabecular, but in MDS, more of them, they shift and they proliferate in the central parts of the marrow. This is the CD34 positive. Here you find these are the blast cells. One cluster is seen, what we call as ALEP. These are CD34, 117 positive. And these are seen in the intertrabecular spaces in the central parts of the marrow. Another case of MDS, again demonstrable on CD34, CD117. You suspect that these are blast cells, and vesicular nuclei, prominent nucleoli, confirm with CD34. But at times we get confused by megaloblasts. Now, these are the megaloblasts in a case of megaloblastic anemia. Now here the megaloblasts are rather well made out because of the nucleus and the nucleoli, which are the longitudinal ones, touching the nuclear membrane. But at times there is fibrosis, little bit of fibrosis. Then you find there is a difficulty. Are these blasts? Are these megaloblasts? So we always use CD71 marker and CD34 for demonstration. Now this is, we found multiple giant cells looking like multinucleated megakaryocytes, but we were not sure. So to confirm what these actual cells are, these CD71 positive turned out to be a multinucleated erythroblast, a feature of dyserythropoiesis. Now these are the multinucleated megakaryocytes where the nuclei are wide apart. And of course, if you do CD61, this is on bone marrow refined biopsy, you see these disc megakaryopoietic cells. Another thing is micromegakaryocytes, which is a feature of disc megakaryopoiesis. You can make out on CD61. These are the two micromegakaryocytes. Here you find another micromegakaryocyte. Here again, these are two micromegakaryocytes. And then, of course, these are different sizes, size variation. There are the nuclear abnormalities in these megakaryocytes, which can be appreciated on HND as well as on CD61. This is a 5q deletion where you find that the cytoplasm is mature, nucleus is round to oval, and almost all megakaryocytes are like this. And you can confirm with CD61 for megakaryocytes. For cellularity and stroma, we can use CD34 and various other stain. Hypoplastic MDS is uncommon, but yet you can see here the blast cells are present, and these blast cells are CD34 positive. We can count the number of CD34 positive cells amongst all cells. And this is a very difficult diagnosis at times to be made, where we find MDS with marrow fibrosis. Dysplasia is present, so we have to count the blast cells, see to it that fibrosis does not hamper in making the correct count of the blast cells and the morphology of megakaryocyte or other cells. Keep in mind that when we do the CD34 counts, we are using CD34. CD34 also gives color to the megakaryocytes. So the megakaryocytes are weakly CD34 positive. And here you find that these are the blast cells and the megakaryocytes. So what is the take-home message? Immunohistochemistry is a valuable adjunct in the diagnostic workup of acute leukemias and MDS. What does it enable us to do? Lineage assignment and blast characterization, whether it is a B, T, myeloid, and the characterization and maturation of the blasts. So the correct diagnosis of the malignancy is made so that optimal treatment can be instituted. CD34 is very, very useful in characterizing the suspicious blastard cells. Immunohistochemistry facilitates accurate subtyping, and that guides for further molecular testing also from the block. It is not a replacement for flow cytometry or for molecular studies, but it is an indispensable tool in cases where the marrow is not available because of the dry tap or inadequate marrow, or for some reason or the other, we are not able to do bone marrow aspirate again. So what is needed is that we have to integrate all these findings of immunohistochemistry with morphology and with cytochemistry to arrive at the correct diagnosis. Thank you very much.
Thank you so much, sir, for that. Again, a very fantastic, superb lecture. It was very, very crystal clear and worth learning from you, sir, always. Thanks a lot. Hats off to you, sir. And I request now all our discussants to please put the hand raise sign so that we can start our question answer session with sir, Dr. Tejendra Singh, sir.
Can I just ask a question from Tejendra Singh, sir?
Yes.
Sir, good evening, sir.
Yes.
Sir, I just today, sir, there was an adult male and he had pancytopenia, and the patient was on azathioprine for last 3 years, and the bone marrow was dry tap, and we couldn't even prepare the imprint. And with the trephine biopsy, it all showed necrosis and gelatinous transformation. And when I prepared the trephine, but when I saw it very carefully, I found there were that necrosed blast cells. And when I had that trephine wash, the Giemsa stain clearly showed that they were necrosed blast cells. So I have ordered for CD34. Now, my question to you is, will that work in cases of blast cells which are necrosed? And should I ask for more ISC, sir?
See, I showed you one case of myelofibrosis, compactly cellular, and the third one was a bone marrow necrosis. Now, whenever there is a bone marrow necrosis, there is an article by Basu et al. In which what he has shown is that even the partially necrotic cells give a positive reaction with many of the markers. That is number one. Number two is, as we take the multiple sections in these cases, what we find is that somewhere down the line, we come across few viable cells which give positive reaction with various markers, and then you can arrive at a diagnosis and treat it accordingly.
Right, sir. So, sir, am I right to, I have just ordered CD34. Should I order for more markers as you showed in the flow chart?
Absolutely. So
Okay.
that 34 will just give us an idea that so many blast cells are present.
Right,
But
sir.
we want to confirm for MDS that they should be myeloblasts. So CD117, 33, these should also, along with the MPO,
Right, right,
should
sir.
be carried out.
And sir, E-cadherin, sir, was Basu sir had shown us that it is a very good marker for early erythroid cells, but that was missing in your early panel, but subsequently you showed, sir. So, what do you have to say about that? And then CD34 is positive, strongly positive in dysplastic megakaryocytes. Your comment.
See, I showed you in the end one megakaryocyte which was in a CD34 stain slide.
Ji.
So CD34 stains, of course, the blast cells, but also the megakaryocytes, which are showing dysplasia. Those cells may show megakaryocytes, may show the positivity. So there is nothing to be alarmed that something wrong has happened. It is very correct, so that thing goes on.
Right.
Second thing is E-cadherin. Now, E-cadherin is a marker for proerythroblast. The very early stages of erythropoiesis is positive E-cadherin, but as the proerythroblasts mature to early normoblast or early erythroblast, you find then it turns out to be negative. So this is a specific marker for our M6 or acute erythroid leukemia.
Right. Thank you, sir.
Thank you, Dr. Professor Vijay Tilak, sir. Madam Tara Roshni, ma'am.
Good evening, sir. A lovely presentation as usual. Sir, I wanted, you did speak about P53, but I just wanted to highlight that we used P53 IHC on all high-risk MDSs, and we did the grading and things. And the ones that had higher were the ones that got transformed into acute a few years later. That was one thing. And also P53 I found very useful to differentiate erythroleukemia from florid erythroid hyperplasia. We did have a patient who on subsequent biopsies kept showing this erythroid hyperplasia, but they weren't looking like blasts. And so then I read about this and I did the P53 and it was strongly positive. So then we had to change the diagnosis.
This is a very good observation. I think we all, those who are doing immunohistochemistry, it will turn out to be very, very useful, especially to differentiate between megaloblastic anemia and MDS, where at times we land up in trouble.
Yes, sir.
It is a very good observation. I think at least we will start up right away for such cases. Thank you so much.
Thank you, Dr. Tara Roshni Paul, ma'am. Dr. Basu, sir.
Yeah, good afternoon, sir. And as usual, very, very beautiful talk. So I had just a few things which Dr. Vijay Tilak also said. We have had good experience with E-cadherin. As you rightly said, it is seen in proerythroblasts. It's also seen in dyspoetic erythroid cells rather than the normal. It is seen in early megaloblasts also. Between E-cadherin and CD71, because CD71 highlights all stages of erythroid cells, we prefer somehow using the E-cadherin because it is highlighting that very early population of cells, which help us in MDS, highlighting the erythroid lineage in MDS, or even in regenerating marrows. Between a blast versus an erythroblast, it is useful. Glycophorin on trephines, we have not found it useful because it highlights even the RBCs. So the background hemorrhage is all taken up. So somehow we have been more fond of doing E-cadherin because somehow it serves the purpose a bit better for us. The other point that Dr. Vijay also brought about, and you also said that in necrosis, we've had our experience, especially with the lymphoid markers, TDT, CD10, they are retained. This is that phenomenon, what is called of necrobiosis. So as long as the cells are not fully degenerated or necrosed, they do retain their antigenic property, and both cytoplasmic as well as nuclear. Even TDT we have found to be positive in, like you said, we have also had a few cases where the initial presentation was with tumor lysis, spontaneous tumor lysis. So the marrow was totally necrotic, but we were able to highlight the blast because flow didn't help, but we were able to pick up the blast lineage on immunohistochemistry. So these are the points that I just wanted to highlight in this. So thank you very much for your presentation.
Thank you.
Thank you, sir. Dr. Rashmi Kushwaha, ma'am.
Good evening, sir. Thank you for the lovely presentation. Sir, my query is regarding many times we come across a hemodiluted marrow and the trephine is showing diffuse fibrosis, grossly as well as on the reticulin. And if we want to rule out the blast in it, then IHC does not come very well because those blasts are not delineated. So how to go about it? Should we just write it as bone marrow fibrosis? Because
No, see, the idea is to tell the clinician whether it is ALL or AML. Cut as thin section as possible. You will be able to stain the blast cells.
Okay.
We have done it in cases wherever the fibrosis is more, reticulin is more, very thin sections, the blastic nuclei are made out and the staining comes out pretty well.
Okay.
It should be around about 4 micron section. You will be able to help the clinician.
Okay, sir. And sir, I have one more query. In follow-up cases of myeloma, when we do bone marrow aspirate, how to quantify the CD138 positive cells on the trephine section? Because many a times the clinician asks, हम बोलते हैं कि CD138 plasma cells दिख रहे हैं. They will ask, okay, how many percentage? So can we, is there any way to quantify the percentage of these cells on the trephine section?
See, as and when we do markers or we do immunohistochemistry in a case of multiple myeloma or in a case of plasmacytosis, you do hematoxylin, give, say, for if you are giving 5 minutes for all others, such a slide may be given 7 or 8 minutes. You will find the nuclei are very well stained. You can easily count a CD138 stain or a CD38 staining pretty well. And you can give the actual number of plasma cells in percentage, 10 to 15%, 15 to 20%, or 60 to 65%. You can easily count, provided hematoxylin is slightly darker.
Okay.
Any other question, Dr. Rashmi?
No, sir. That's it. Thank you, sir.
Thank you. Dr. Shilpi, your question.
Thank you for such an enlightening lecture, sir. I had a query regarding CD68 immunohistochemistry. I often encounter significant background staining while using CD68. So in your experience, does CD68 IHC give such a background? And
No.
which clone would you recommend, KP1 or PGM1 for
See,
the...
we are not using the K1 clone. We are using the TG1 clone. And there is no background staining at all. The only thing is, in a particular case, there are macrophages, which of course will be stained, but dendritic cells are sometimes increased. And those dendritic cells, you will find plenty of dendritic cells present in the background. So that creates trouble. So that cannot be helped. Again, a thin section. You thinner a section, you will find that the dendritic cells are very well made out. You can see even the processes coming out of them which are positive, and those will be separate from the macrophages. Some of the macrophages will also show you hemophagocytosis.
Okay,
That
sir.
gives a clue that these are the macrophages.
Thank you, sir.
Thank you, Dr. Shilpi. Sir, I have some few questions for you. One is regarding CD123 stain.
CD?
CD123. CD123. CD123.
1, 2, 3.
So is CD123 positive in all AML?
No, it is not positive in all AMLs. That is why CD123, if you have seen throughout, I have not used CD123. It is not the recommended marker.
Okay. And second is regarding APML. Are all APML will have aberrant CD64 expression positivity?
No. APMLs are CD34 negative. Those are HLA-DR negative. MPO positive, CD117 positive. On flows, sometimes you come across CD15 positivity in some of the cases, but not a routine thing. No.
CD64 absent.
No, CD64. See, the thing is, the variant type, the cells are appearance is monocytoid, but the quality remains the same as that of hypergranular. It is extensively positive with MPO. It is just loaded with myeloperoxidase.
Okay.
It is loaded myeloperoxidase. It may appear monocytoid. We may think that CD64 will be positive, but by and large, CD64 is not positive in these cases, because CD64 is more positive in promonocytes and monoblasts rather than in promyelocyte.
Thank you, sir. There are some few questions coming up from the audience. One question has come from Dr. Pushpanjali. Which marker should be used for secondary HLH in young female patients?
HLH, we have to use CD68. Actually, the case which I showed where there were too many macrophages with bubbles, those were the phagocytosed red cells. And CD68 is very good, fantastic marker. I'm every day using CD68 for HLH cases. Wherever I have a doubt, I do use it.
Thank you, sir. Another question from Dr. Jyotish Taune. Are all AML M6 patients TP53 positive?
Are AML M6 patients
TP53 positive?
CD56?
TP53. T53.
Yes,
TP53.
I think majority of the cases, though these are recent studies, as Basu was telling, these are recent studies because earlier we were not aware of the TP53 mutation which was occurring in these cases, but now we know that biallelic mutation is occurring, and P53 is by immunohistochemistry stain we can demonstrate. It is positive in majority of the cases, resulting in a worse prognosis. Actually, M6 has got a very bad prognosis because of that.
Yes, sir. The same, I wanted to say that for M6, T53 is a marker that we have started to use now very regularly. It's a rare leukemia, but whichever cases we've got of pure erythroleukemia are all TP53 positive.
Right.
So cadherin and TP53 are something that we are using now.
And they also usually have complex phenotype also, mostly. Another question is from Dr. Yimon Tent. CD19 positive, CD10 positive, CD34 positive, CD19 positive, CD10 positive, CD34, CD117, TDT 2079A are negative. Can this be a normal? Means whether this can be hematogones or leukemic cells. So only 19 positive, 10 positive, 34 negative, 117 positive, TDT negative, 20 negative, 79A also negative.
See, there is a beautiful article by Naresh Kikeri. You must be knowing. A beautiful article on hematogones. And he has been able to classify hematogones on immunohistochemistry. And what he has mentioned is TDT is less than CD34, CD34 is less than CD19, and there is CD19 is less than PAX5. These are the 4 markers he has used. And then he has said that since hematogones are in different stages, that is, immature one, you will find TDT and 34 positive. Then a mature one, where you will find PAX5 is positive and CD19 is positive. So we find a particular ratio depending upon the case, when the case has come or when the marrow regeneration started. But all these 4 markers are positive in these cases in varying proportion. We have tried, I have tried in some cases where they were there hematogones. I could make out the diagnosis on Giemsa stain, but it was rather difficult, I must admit, that to say categorically, yes, this is a percentage of the hematogones. Difficult job, I must say. But somebody can read that article. It is a beautiful article, and there is no follow-up article after that on hematogones. I wish he had written that so that we can distinguish hematogones from the blast cells and from the normal lymphoid cells.
Thank you, sir. And this is from Dr. Naresh Kikri, sir.
Naresh Kikeri is now in USA.
Yes.
He's a hematopathologist.
Yes. Okay, sir. Thank you so much, sir. Another question is from Dr. Negasa. Is it must to do only, if it is must to do only one IHC to diagnose AML, which one would you recommend?
MPO.
Straight away answer. Yeah. Right. One more question. Yeah, one more question has come regarding the CD123 again. Can CD123 differentiate between blast and plasmacytoid dendritic cells on IHC in cases of suspected AML with PDCs differentiation?
See, in PDC, the other markers are also positive. We have to do not only CD123, but CD16, CD56, all those markers, also CD4. These are the markers we have to carry out. And then with morphology and ruling out, actually, we have to rule out that it is not T or B or AML. Only then we start thinking on the lines of whether we are dealing with a dendritic cell neoplasm or not. And then we go about these and differentiate it from all others. Not on one marker, please. Rather, one should take a message that one marker is we are treading on a very slippery path. We should always do a panel of markers to be sure so that the patient gets benefit. Once we tell the clinician it is ALL or AML, B or T, then only he will treat. Otherwise, he may be again doubtful. So we have to help him out.
True. Thank you, sir. Dr. Vinayak Chikodi, your question, please. Dr. Vinayak.
Hello.
Hello. Good evening.
Yeah. Sir, you're muted, sir. Sir, you're muted. Sir, please unmute yourself.
Yes, Dr. Vinayak.
Sir, can you unmute yourself?
Huh?
Okay. We'll go with Dr. Shilpi. Dr. Vinayak? Yeah.
Yes, sir. You can, sir.
Yeah, Dr. Vinayak.
Yes.
Go ahead.
Can you hear me, sir?
Yes.
Sir, are
Can hear you.
thrombosis and increased megakaryocytes a feature of MDS with isolated del 5? You can't, sir?
No.
No, we cannot hear you,
The
sir.
question is not clear again, please.
Just a
Sir,
moment,
you
sir.
can type in the chat. You can type in the chat box. Sir, if you can please type in the chat box, that would be better, sir. Dr. Shilpi, your question, please.
Thank you, sir. Sir, I had a patient, 3 years old girl. She came with fever and pancytopenia and grade 3 neutropenia. Bone marrow aspirate was done and it showed 3.3% normal blast on cytometry. So these were also showing expression of CD86. Since the percentage was only 0.2% and on morphology percentage was only 12% blast. So we waited for bone marrow biopsy, which revealed one bone marrow space with sheets of PAX5 DDT positive blast. So I gave it as BLL. Then the clinician was not, he was not convinced that it could be BLL. So they waited. For around 1 month. By the time DUX4 rearrangement had come in the sir, the patient lost to follow up after 2 months. When she came back, the counts were normal, and no steroid was given to her. Only a blood transfusion was given since her HB was 3 at the presentation. So I don't know whether I diagnosed it correct or not. If you can enlighten me on this case.
Were there any blastoid cells present in the peripheral blood also at that point of time?
Sir, peripheral blood, there were few suspicious blasts, so I did flow cytometry on peripheral blood also. So around 1.1% came.
See, 1% presence of blast is, I don't know, difficult to say. But the fact remains that those cells could have been transformed lymphocytes, which were showing you blastoid morphology. And the patient recovered from viral fever. And that's it.
Sir, but these cells did not show histone arrangement in the flow cytometry, and all of them showed aberrant expression variable of CD86, and DUX4 rearrangement also came positive. So I don't know.
Was the patient given GCSF?
No, sir, no GCSF. Only transfusion was given.
Because GCSF induces changes in the blast cells, and as a result of which you find that there are abnormal aberrant markers also which are present. And then following that, as the neutrophils come up, you find then the normal blast cells start coming up. So it is not uncommon because we don't get a history whether the patient has been given any GCSF or any such drug. So we think that these are all blast cells, but actually those are blastoid cells which have been released from the bone marrow as a result of giving GCSF. So that point we must keep in mind, and we should emphasize on the clinician to provide us a data whether what all treatment the patient has taken. Otherwise, such mistakes could occur.
Sir, but even then, sir, DUX4 arrangement, I read the literature, it is not seen in normal B cell. So how do we explain that?
See, unless one has a look at the morphology, it is difficult to say, because if they are insisting that those were blast cells, but then he did not give any treatment for the simple reason that probably he had something at the back of his mind. And now at least he should tell that why did he not start the therapy at that point of time? Because he waited, he knew probably that the patient may not be a case of MDS. So that is why he waited. So either GCSF or any such drug, if you sometimes patients take homeopathic and Ayurvedic drugs, which induce severe degree of myelodysplasia. And we find that after a month, his counts are normal, everything is normal. It has happened. And we do come across such cases every day. So maybe this is one such case to be aware of, and we should be very, very careful in declaring. Rather, we should not declare blast cells. We may say blastoid cells are present.
Thank you, sir.
Thank you, Dr. Shilpi. Dr. Vinayak Chakudi. Are you there now? Okay. Sir, you can type your questions in the chat box. We'll go with Dr. Rashmi Kushwaha. Your question, please.
Sir, my question is regarding the technical aspect. The problem we face in doing IHC on the trifine section. Actually, I have observed that on the trifine, the IHC does not come so beautifully and so easily as compared to the other tissue. So, is there any other protocol like more of denaturation or more time for antigen retrieval that we can follow so that the IHC comes easily on the trifine?
See, what is important is two things. One is decalcification. That is the most important thing. If you decalcify in EDTA, the epitopes are preserved and you will get good immunohistochemistry staining. If the epitopes are destroyed, which can happen with excessive heat and which can happen with strong decalcifying agents. So use EDTA, use it for at least 24 hours or overnight. That is for decalcifying agents. And don't use any strong acid like HCl or nitric acid or any such acid.
So what about formic acid? Like we have been using formic acid in our lab.
Formic acid is good enough, provided you again use it at least for 6 to 12 hours, because it is a weak acid, so it takes time. But I must tell you that with formic acid versus EDTA, EDTA is better than formic acid.
Sir, what about the morphology preservation?
Morphology preservation is equally good in both EDTA as well as in formic acid. If you don't, for some reason or the other, EDTA is not possible, you can go ahead and start with the formic acid.
Fine, sir. Thank you, sir.
May I say something in this point regarding this is Basu here.
Yes, sir. Yes, sir.
1 minute. So regarding what we have been using is what Dr. Naresh had prescribed, the Hammersmith protocol. That starts with acetic acid, zinc, and formalin. There is acetic acid in the fixative itself, in the decalcifying agent. So we keep it for about overnight. Acetic acid, zinc, and formalin decalcifying agent, followed by formic acid for 6 hours. And our decalcification and the immunohistochemistry comes out very well. Morphology is very well. Agreed, EDTA is the standard without shade of doubt, but EDTA takes a slightly longer time. So that's why with this Hammersmith protocol, we are able to report on a trifine biopsy within 48 hours. 48 hours, we just keep it overnight in AZF, the decalcifying agent, and 6 hours in formic acid. So if necessary, if it's needed, urgent reporting within 48 hours, we are able to get out at least the HNE and then IHC we perform. So that's a alternative. We have been using it for the last almost 10 years now.
But B5 solution is not readily available here.
No, we don't use B5, sir. It's neutral buffered formalin. The usual formalin, acetic acid, zinc. I mean, I can send the exact proportion. I don't offhand remember. Acetic acid, zinc, and just neutral buffered formalin, followed by formic acid decalcification 6 hours.
Sir, I'm Dr. Parimal here. Basu sir, we are also using Hammersmith protocol. And after that, the IHCs come very nicely, as well as molecular also give the result.
Thank you,
We're also using it and it's doing good.
Same here. We are also using the same protocol. Dr. Deepa Rani, you have a question?
Hello.
Yes, please.
Hello. Good evening, sir.
Good evening.
Thank you so much, sir. Such an informative talk. Sir, I want to discuss about one case. I diagnosed that case as HLH 2 times. And she was 3-year female, a child. And sir, now she died due to her disease. I don't know what is the diagnosis of that case, because sir, in our first diagnosis, there was clear-cut evidence of hemophagocytosis in the bone marrow. And after 6 months, again they have done this bone marrow aspiration and biopsy, and there was the clear-cut evidence of hemophagocytosis was there. And what unique thing I found in that case, the macrophages, the histiocytes were having the vacuoles. Many vacuoles were there, and myeloid cells were also showing the vacuoles. Many vacuoles were seen in the myeloid cell. So I thought that this may be a case of some histiocytic disorder. But now the patient died, and they could not perform that molecular studies and all that. So what ISC we can use in the bone marrow biopsy? We can use what ISCs?
See, IHC is very, very useful. A, to confirm that those are macrophages. And second is that it also helps us in knowing what all is present in the macrophage. See, you should have done PS stain or fungal stains to confirm
Okay.
if there was fungus in those vacuoles or not,
Okay,
along
sir.
with the presence of
Hmm.
the various phagocytose cells. So
Okay,
that
sir.
that would have helped you in picking up the underlying disease.
Okay,
The
sir.
very fact that the patient was ill for about 6 months and
Hmm.
hemophagocytosis persisted indicate immunocompromised patient
Yes,
this
sir.
was already. So we should have gone for maybe assessment of immune status by flow cytometry or
Mm-hmm.
by other methods. And accordingly, sometimes we come across patients of A gamma globulinemia or
Okay.
patients with DGeorge or Neziloff syndrome, which
Mm-hmm.
have got T cell defect. So
Okay,
those
sir.
can be picked up in such cases.
Okay. Thank you so much, sir. Thank you.
Thank you.
Thank you, Dr. Deepa. Dr. Neema Thanda, your question.
Thank you for your very informative and comprehensive talk, sir. I have two questions. Which are the must to stain IC in to diagnose acute leukemia? This is my first question, sir.
Which are the?
Must to stain IC.
See, I showed a slide in which
Mm.
first thing is that we have to see that these are immature cells. So we have
Yeah.
to do CD34, TDT, HLA, DR, CD117. And then CD3 and PAX5. These are the must 6-7 markers you should carry out in each case if you are doing immunohistochemistry. Then, of course, depending upon the morphology, if you feel there are monocytoid cells, then we have to do CD68 as well. If we find they are like proerythroblasts, then we have to do E-cadherin and CD71.
Yes,
Similarly, for if it is a dry tap and you have got a megakaryoblast, proliferation, fibrosis, then we have to add CD61 for megakaryocytic series.
Yeah, thank you, sir. And the second question is, how can we diagnose leukemia phase of lymphoma from bone marrow sample, sir?
Leukemic phase of lymphoma is actually basically those are the lymphoma cells which are present in the peripheral blood. First thing, as I said, was CD45. If you use CD45, you will find strongly positive in lymphoma cases, very weakly positive or negative in acute leukemia. That is one. Second is TDT. Now, TDT is a fantastic stain because it is positive in 90% of the ALL cases, B-ALL cases, and 95% of T-ALL cases, and only 25% of the AML cases. All AML cases, we go by MPO 117. So the problem is so therefore, I feel that TDT is very, very essential in such cases because it will confirm that it is a leukemic phase. CD45 will substantiate all this. And the result is that you will be able to say whether these are lymphoma cells or these are the cases of leukemic cells which are present in the peripheral blood or in the bone marrow or in the bone marrow section.
Thank you, sir.
Thank you.
Wonderful answer, sir. Perfect. The question from Dr. Vinayak Chikodi is thrombocytosis as well as megakaryocytosis both the feature of MDS5Q, deletion 5Q?
See, the megakaryocytes are increased. Rather, megakaryocytic hyperplasia does occur. This is one condition in which there could be trilinear hyperplasia with cytopenias, because there is a dyserythropoiesis, there is dysmyelopoiesis, there is dysmegakaryopoiesis. So hyperplasia is there, yet there is cytopenia. So what is happening to the cells? They are dying in the marrow itself. So there is apoptosis going on in the bone marrow of these cells. And the life of cells, especially the myeloid cells, is limited because those are all malignant cells which undergo apoptosis. Those are the blast cells. But megakaryocytic hyperplasia is a feature, not like megakaryocytic hyperplasia, what I showed in 5q deletion. That is a separate thing because there is thrombocytosis in that particular type of MDS.
Thank you, sir. Another question from Dr. Professor Vijay Tilak is, how common is to have azathioprine-induced AML?
I haven't come across personally any case of azathioprine, but yes, we do come across where we don't know what treatment the patient had taken. The patient has taken chemotherapy, and after a period of 6 months to 3 years, one comes across development of a hematologic malignancy. It may be in the form of acute leukemia.
Thank you, sir.
Sir, I have some experience with that. Yes, we know that post cytotoxic therapy for different other malignancies, we get secondary leukemias. But apart from that, some of these immunomodulatory drugs, methotrexate and azathioprine, rarely can give rise to MDSs and AMLs. We have a very active rheumatology department which treats long-term these drugs.
Okay.
And we have seen, say, about twice or thrice a year, these
Okay.
kind of cases coming.
Mhm.
So they are different from the post-cytotoxic ones.
Right. Thank you.
Thank you, ma'am. Another question, Dr. Ritesh. How helpful is to have multiplex IHC panels for acute leukemias?
See, if we make the panels depending upon the availability of the markers, I think we will standardize a methodology, and then the long-term follow-up will be very good. I think there is a need, like for flow cytometry. Now they are having a meeting in a few days in Bombay to characterize the panel, that what should be the panel for diagnosis of MRD in ALL, what should be the panel for diagnosis of MRD in AML. I think we do need such discussions and panels to be made, and let us follow it all over the country, and then we can have a long-term follow-up of all these cases. It is the need of the hour, I must say.
True, sir. Well, I finished all the questions from the chat box. Any discussants want to ask any other question?
Sir, I think you will be the right person to lead that panel, sir. And Dev Datta Basu could be there in that, sir. And that will be a big asset to us because a lot of confusion what ISCs we should use, sir.
Okay, sure. I think Vijay will take a lead. I'll take Basu along, and at this Lucknow conference with Dr. Rashmi being around, we can go ahead and do something about it.
Sir.
That would be 2 leads now, sir, for the Lucknow conference. One will be you, another will be Professor Dr. Vijay Tilak.
Vijay Tilak, of course, will be part of us.
Yeah, best of luck, sir.
Thank you very much, sir.
Thanks a lot. And with that, I think there are no more questions, and we'll come to the end. It's a fantastic lecture, wonderful discussion, superb lecture. And I think that was a learning experience from you, as always. You are a wonderful teacher, I may say. And
Thank you so
whenever I
much.
learn from you, it's always a blockbuster learning from you, sir. Thanks a lot. Again, once again, very deep thanks from my heart, sir. Thank you. Thank you.
Thank you so much. Thank you, Dr. Rashmi. Thank you,
I request
Dr. Thanda. And of course,
Sumit
thanks
Kumar.
to you. Thank you so much.
Thank you, sir.
God
Mr.
bless
Sumit
you.
Kumar Madan from Zydus to go for final word of thanks.
Thank you, Dr. Tajinder Singh, for sparing your valuable time. Sir, it was an excellent presentation followed by a very, very engaging discussion. And I think overall it was a marathon session from your side. first the talk, and then everybody had one or two questions, and you addressed all the queries in a very, very proficient manner, sir. And we have many key takeaways from this wonderful presentation. On behalf of Zydus, I also thank Mumbai Hematology Group, Dr. M.B. Agarwal, sir, for providing us this wonderful opportunity and making us a part of this esteemed academic discussion. I also thank all the discussants and participants who have joined us for this webinar. Special thanks to Dr. Amit Kurana for navigating this entire program in a highly proficient manner.
Yes.
Last but not the least, this series of webinar is possible only because of continuous support from Perfect Square team. Thank you so much, everybody, and have a wonderful weekend.
Right. Okay.
you.
Thank you. Thank you, everybody.